This is Jim Mold, and I'm speaking today with Dr. David Reuben, who's the director of the multi-campus program in geriatric medicine and gerontology, and chief of the division of geriatrics at UCLA. He's also a professor and the director of the Claude D. Pepper Older Americans Independent Center and the Alzheimer's and Dementia Care Program. I get that approximately correct?
No, actually, almost none of it is correct, but one thing still is. I have not been director of the Pepper Center since 2000, I think 19, but more importantly, in 2024, I stepped down as division chief and director of the multi-campus program in geriatric medicine.
Oh, I'm sorry. This was
Gerontology.
information off the internet, so I'm
That's right. Well, the
not.
internet is a little behind here, so don't trust everything you get on the internet, but it is behind. So right now I'm Archstone Professor of Medicine and director of the UCLA Alzheimer's and Dementia Care Program and UCLA's Guide Initiative.
Okay, good.
So
Well, the reason I'm
that's
talking to you is because I first met you after you had published a paper in the New England Journal called Goal-Oriented Patient Care, an Alternative Outcomes Paradigm. And I think we met briefly in Washington, D.C., and have had little contact with you since then. So I'm interested to know what's happened in your world with regard to goal-oriented care, particularly I guess I'd be interested in how you teach about it, how you teach. I know you see medical students and residents and fellows, and what do you tell them? How do you describe it to them?
you know and I will confess my shortcomings here. In a sense, I don't do that much teaching. I do teach, and I do teach in the clinical setting, but mostly on the inpatient service to residents. And there I do a lot of goal uh, uh, oriented care teaching. It's kind of asking the residents what's important to this patient and how can we achieve it? How can we get there? And one of the things I do is correct them all the time. When they talk about goals of care, they're always talking about whether to intubate somebody or to beat on their chest if their heart stops beating. And those aren't goals of care. Those are advanced directives. But goals of care is I tell them, is what do they want in 3 months, 6 months? What do they want? What do they want to achieve? And we have done this. I've had them sit in or lead goals of care conversations with families. One of the ones that is kind of uh, most memorable was a patient of Lee Jennings, who you know very well, uh, and from University of Oklahoma. And this lady had pretty much end stage esophageal cancer. And this is somebody that a medical student would know that they're not going to be alive in a year. I mean, it just was not in the cards. And we talked about we had a whole family involved in this conversation, and we talked about what's important to her and what she would like. And there were interesting things. There was one is that she wanted to be able to eat something. Number two was she wanted to be able to go to museums. Number three was that she wanted to, I think, get out of the house and go to some clubs that she was doing. And then the last one was that she wanted to be able to pray with her family. And we wrote these up, and it's interesting because I cared for her in the inpatient service, and then I asked Lee about, she died a few months later, and asked her, what was she able to attain and get and do. And she says, I think the last one, I think she prayed with her family, and it was important to her. So I do tell this story a lot. I tell it in my didactics teaching, and I think one of the things I do a lot, because I'm pretty advanced in my career, is I won't say pontificate, but I will say I give a different perspective about patient care. One of the things I always tell my residents is get the patient's story. Who were they? What did they do? What are they proud of? Because almost everybody is a hero. And we've had some patients who marched in the civil rights movement. I've had patients who have been in film and industry and government and done some pretty amazing things. And others that are just heroes to their family, and their families love them. So it's the whole idea of kind of shifting, from the approach of which antibiotic to the bigger picture and thinking about how you interact with all of your patients. And it's a lot about kind of doctoring. It's not the kind of stuff that is so much scientific rigor, but it means a lot to people.
Are you familiar with narrative medicine? I'm sure you are.
Yes, I am.
Yes.
Rita Shalom? Yeah,
So yeah, so
yeah, yeah.
it seems to me that this is a useful add-on to narrative medicine. I mean, I think narrative medicine makes a lot of sense, but it doesn't tell us what to do clinically. But I think the way I think about goal-oriented care is it gives you guidance with regard to how to apply medical science to help people have a better story.
Agree. And the story is their story. And that's one of the important things about goal-oriented care. It's not the doctor's story. It's not how I healed you. It's your story, how you got to what you wanted to be, and what state that you wanted to attain.
Yes, I agree. You do see dementia patients, correct?
Yeah, and so this is something we've actually done some research on. And Lee was deeply involved in this. We had a grant from PCORI to look at goal-oriented care in persons living with dementia. And we held focus groups with caregivers of dementia. We held focus groups with people with dementia. And we created an inventory of goals. And then we had goal setting as part of our clinical care in the study, actually. It was integrated into the work of the dementia care specialists, nurse practitioners. And then we looked at how often, we looked first of all at what goals were set. And the goals could be set for the person living with dementia or the caregiver. Because if the caregiver wants to be able to preserve their own mental health, that's pretty important to the patient. So we did that, and we published that maybe in 2019, 2020. But the other thing that we haven't published yet is, and Lee is actually working on this as well, is that in the DCARE study, which was a study of 3 different approaches to providing dementia care for, I think, maybe 900 or so people, we did goal attainment scaling with their caregivers about what the goals would be. And we're starting to get those results. They're not finalized yet, so I can't speak much about them. But the point of the matter is that we're going to have turns out to be a very large study of people with dementia, what their goals are, and how often they were able to attain them.
I look forward to seeing that.
Yeah.
Can you speak a little bit about how patients and families respond to this approach?
I think they like it. I think they like it. In fact, maybe on a different study that I wasn't the lead on or senior on, I think they actually preferred it to other kinds of instruments because they felt that it really got at what was important to them. And this gets into that whole priority care, et cetera, that Mary has championed, that, it's concordant with their values, but, it's what matters to them, and to use one of the four M's. And I think it is catching on more. Not for all doctors. For some doctors, this is kind of as remote as as psilocybin, but for some doctors, they get it.
It seems to me that for us to make progress, I mean, there are huge obstacles, not the quality metrics and electronic medical record and a whole variety of other obstacles. But it seems to me that one of the things we need to do to make progress is to pull together the groups of people who already have embraced this and have been doing it for years and just haven't called it that. So, I mean, my daughter is an occupational therapist. Occupational therapists are goal oriented by nature. That's what their training is. Sports medicine physicians are goal oriented. Palliative care clinicians are goal oriented. Mental health professionals are goal oriented. At least a portion of them are. If we could pull all those groups together and come up with a common language,
Yeah,
it seems like we would have a lot more success in promoting this across healthcare.
I agree. I agree. In fact, when I first got into this, I kind of got into it through Ken Rockwood's some of the stuff he was doing, but also that I tend to follow trails backwards. And I found the first published article I find on this was in Mental Health from the 1960s, and then who took the ball and ran with it were physical and occupational therapy. It's all about goals. And and medicine has been latecomers in a sense, but it's certainly equally as valid. I do agree also that there are enough people around who are interested in that it could be a movement. And I don't know, this may be something that there could be a conference grant, like an R13. I think that'd be very interesting, and some people who've done a lot of work, kind of a little differently. Mary and I are still close, but we kind of diverted a little bit at some point or another because I was much more, I was very interested in kind of individual goals and operationalizing this, and she was much more interested in the clinical practice type of thing. But we have we're very complementary on this.
Yeah, I think
And like 90% of it we agree, and 10% we're just focused a little differently.
I agree with you that a small conference grant would be a good idea. And I even drew that up and had it all planned out and had a list of invitees and so forth about the time I was retiring. So I didn't ever pull it off because we had another big grant that we had to write at that time. But I think that we need to keep thinking about that idea. It wouldn't be I mean, it would be hard work. I mean, we'd have to come up with common terminology and common conceptualizations, and it actually is difficult work, but I think it could really be effective.
There's several ways of doing that. One is somebody or a consortium of people can write a conference grant. The second is sometimes the NIA will be interested in maybe having a NOFO or an RFA around something like this, and they sponsor it themselves and invite people who are very prominent in the field, and that's also quite successful. And then the third way is like through the National Academy. And those tend to be a little more expensive, but they get a lot of stature and prestige. to them. And if there was a foundation that might be interested in that, I'm certain that there would be people in the national academies who would be interested.
What do you think about Hartford or RWJ? What foundation did you have in mind?
Well, Hartford might be interested in it. You know, the four M's were Terry Fulmer's legacy, one of her legacies. And I think that Ronnie Snyder, who is now the president, also has, understands this and gets it. I don't know what RWJ is doing these days. I haven't been in touch with them much at all. Um, there may be some other foundations. I'm just trying to think.
Well,
Um,
let's keep in touch by email, you and me and
yeah,
Mary and Lee and some other folks, and see if we can't figure out how to make that happen.
yeah, and what's his name at UT Houston has also been very uh, Anan Anayak.
Yes, yes, yeah. I've been on conference calls with him.
Yeah.
Great. Thank you so much, David. I know you're busy. I
All
appreciate your
righty.
time, and hopefully we'll
Well,
stay in touch.